Good morning and welcome. We are so pleased that you're joining us this morning for our April webinar, High Quality Primary Care, A Path to Healthy Communities. By way of background, the Texas Primary Care Consortium is the only statewide collaborative with a mission to advance high quality primary care for all Texans. We are co-led by the Texas Health Institute and the Texas Medical Home Initiative. Our priorities are to increase access to high quality, cost-effective care, to improve the financial stability and vitality of Texas primary care system, and to strengthen the primary care system overall. We could not do this work if it were not for our generous partners who you see featured on this slide. We are so excited today to have three dynamic, effective, thoughtful leaders in primary care on this webinar with us today. The moderator is Helen Kent Davis. Helen is the Senior Associate for Health Policy at the Texas Health Institute. She brings a world of experience and wisdom with her to our work. She is joined by Dr. Kimberly Avila Edwards, who is a pediatrician. She's Associate Chair for Advocacy, an associate professor of medicine at UT Dell Medical School, and she's a practicing pediatrician at the Austin Regional Clinic. And finally, Dr. Emily Briggs. Dr. Emily Briggs is a full spectrum family medicine physician. She'll probably tell you more about that. And she is owner of Briggs Family Medicine in New Braunfels, Texas. So with that, I'm going to turn it over to you, Helen.
Thank you, Sue, and welcome, Dr. Edwards and Dr. Briggs. I'm so happy to be with you and all of our participants. You both have drawn a lot of diverse people from different backgrounds, and look forward to talking with you today about how we can advance high quality primary care in Texas, which of course is a top TPC priority. And I know for both of you is something you've worked on professionally for many years. So the learning objectives were shared with everyone prior to this webinar, so we're not going to go through them, though if you have any questions about them, feel free to plop those in the chat and we can circle back, but those are the objectives and we're going to just get right into the heart of our webinar. So the next slide, we just wanted to explore a little bit, as background, why we're talking about the need for high quality primary care and how we do that both at the individual practice level and within communities. Texas, according to America's Health Rankings, ranks 40th in the nation. And that score is a composite one made up of many different factors. If you're interested in learning more about how the rankings are done, you can refer to America's Health Rankings. Their website is a wealth of information. But the parts of the composite score that were particularly important to today's talk are ones relating to social and economic issues, which are relate to non-medical drivers of health, which we're going to talk about, as well as clinical care. When you look at our social economic score, we ranked 42nd in the country, and that includes things like food insecurity and economic hardship, things that we know contribute to people's challenges to live healthy lives or to actually obtain health care in the first place. And then clinical care, we ranked 50th. Gosh, in Texas, we have so many wonderful, amazing medical centers and physicians, nurses, clinics. And so it's disappointing to see that's where we are, but that is the reality of our state, and we know we can do better. But that contributes to chronic disease and our ability to effectively address people's health and to improve it. So just bringing this to your attention. Interestingly, just a decade ago, Texas scored much better. We were 31st in the country, not 40th. So as we all work collectively to improve the health of Texans, we have done better in the past and we can do better again. So moving on to our, getting into our conversation, we could go on from here. And I just want to mention that for the audience that due to some technological issues, I do have to go back and forth between my tablet and the screen to see the questions. So I don't want you to think I'm paying attention as a moderator. But first of all, since we are talking about high quality primary care and both of you are practicing in those fields of different aspects of it, talk a little bit about why you chose primary care in the first place. It's interesting always to hear from physicians, and you had to make that very crucial decision as young medical students and looking ahead to your futures. So I'll start with you, Dr. Briggs. What was it that drew you to primary care?
So in my training, in my medical training, I certainly, as a young child, I had my own family doc. I had my own primary care physician who was quite meaningful in my world. He helped guide my family through our care as myself and my siblings got older and older, and through various medical issues that the family had. And so that was something that was near and dear to me in my youth. But then through training, when we go through medical school, we're given an opportunity to get into all the different specialties and see what it's like to be a practicing physician in each of those specialties. We call those our clerkship years or clerkship months. And during that time, every single specialty that I was gifted the opportunity to be involved with, I absolutely loved and was passionate about. And so every one of them, I actually started out with pediatrics, then surgery, OB. It wasn't until the end of my 2 years of clerkships that I found family medicine and thought, oh my goodness, I can do some of all of this. That's perfect for me. And that meant that I could manage the care of families from the beginning of life to the end of life, everything in the middle, including delivering babies, including seeing people in a practice, but also taking care of people in the hospital. And it's that continuity of care for me that brought me specifically into family medicine, to be able to manage the care of the child, but also of the parents, of the grandparents, because all of that has to do with the care of that individual, their social surroundings, all of the things that, as we call the non-medical drivers of care, all of that impacts the medical care. And so being able to be a part of all of that meant that family medicine was my field.
That's lovely to hear. So, Dr. Edwards, you chose the for the beginning of people's lives through your young adulthood, and again, and getting them launched into their adult lives as a pediatrician. So, what made you choose pediatrics?
I think a lot of what you said, Dr. Briggs, really resonates with me. But I will say that I unabashedly believe in the potential of every single child. And I think that came about from the recognition that I was very fortunate in my upbringing to have that. And so I think that is why I specifically chose just to limit to pediatrics. But a lot of what you said, it's that longitudinal relationship. One of the greatest joys, I think, of my career is the partnership that I get to create with parents. And now, having been in practice close to 25 years, I see the cycle of patients who were newborns when I first started, really thinking about that next phase of life or coming in with their own children, and just that opportunity to see that newborn and to recognize there is so much potential. And I am going to try my absolute best to partner with you as a parent to bring about that potential in the best way that I know how, is something that is invaluable and so fulfilling for me.
I really love hearing your stories. I know everybody here on the call does too. We don't get that opportunity very often to hear from physicians about why they chose their particular specialty. But in each of your ways, talking about why you chose it, you kind of hit on the difference. There's kind of primary care, and then there's high quality primary care. And a big part of that is having those relationships. So, talk about in your mind, and I'll start with you, Dr. Edwards. What do you think distinguishes, just, you think of primary care, but if you're really trying to advance the ball, make it more effective and efficient, patient centered, what are the features of that type of practice?
Thank you for that question, Helen, because I think there is a big distinction. And when I was thinking about my definition, all those elements come into the definition. So when I think about high quality primary care for pediatrics, I think it means, one, it has to be individualized. Every individual has strengths, has barriers, and taking the time to find that out is incredibly important. I spoke about the importance of partnerships, and high quality primary care for pediatrics has to be family centered. It has to be equitable. It has to be accessible, whether you live in rural communities or in an urban community. It has to be comprehensive. So children need so much more than just what I can do within the walls of my clinic, and it has to be continuous. We've seen some of the devastation that has come from some of the loss of coverage in children over the last few years. It has to be coordinated so that what I do in my clinic and the asks for help that I get from other organizations or community-based organizations is followed up and is discussed and shared, and it has to integrate with those vital community resources that go beyond what I do in my clinic.
And Dr. Briggs, for you, what to you is the distinction when you think about a lot of the elements that Dr. Edwards talked about certainly impact family medicine, but how would you elaborate on that?
Certainly. So I would say my definition for that high quality primary care really is that comprehensive approach to care. It's incorporating the physical health, the mental health, the spirituality, in addition to those non-medical drivers of care, because all of that allows the team to obtain as clear a picture as possible of a person's world. And then we can meet them where they are so that we can provide judgment-free care and walk with them down a path to improved health. So everything that Dr. Adela Edwards mentioned is exactly what I would incorporate into my definition as well.
Well, thank you. That's a great lead into our audience engagement, the first thing we're going to do. So we wanted to really get feedback from our audience participants who are very diverse, academia, practicing physicians, nurses, clinic managers, you name it. So this is a word meter link on your screen, the QR code. And if you'll take a look at that code, use your camera, and I think there is in the chat also a link to it. We want to hear from the audience. When you think about primary care, what is one word, just one, think about it carefully, that comes to mind? And we're going to use this then to talk more about how we can improve primary care, building on what our audience thinks about it. So nobody's gonna, you can say anything you want. It doesn't have to do, we're not going to see who put in the answer. So, and for Dr. Briggs and Dr. Edwards, if you'll just keep taking a mental look at this, we'll just give it a little while longer. Wow, we're getting some interesting comments. All right. I'm going to give you just a few more minutes. Don't be shy. We want to hear from everybody. Like I said, nobody here knows who put in what response, so you can say whatever comes to mind. All right. Let's stop there. And so I think, we're going to let the our two distinguished speakers talked about what they're seeing here. So Dr. Briggs, I'm going to start with you. And if you've got a good glimpse of everything on here,
Sure.
some interesting answers. So do you want to take a crack at what when you see all these different, sure. How do you think about that?
Well, I love that the first thing that came up was prevention and love. Because that's the compassion that high quality primary care really needs to have, is not only that focus on prevention, and it needs to be comprehensive focus, but also on the compassion. So what I want to touch on though is that coordination of care, because as we know, it takes a full team to provide that high quality care. There are different levels of that team, but it takes every part of that team to be able to coordinate the care to make it effective.
So that's excellent. I'm going to go on to the next question for time, then I let Dr. Edwards respond to the second question, which is a little bit harder. And you think about what is the barriers to accessing primary care. And I think everybody on this call at one point in their life has experienced that because of the shortage we have in Texas. But so think about what is a barrier to it. So interesting that trust came up as one. So keep putting your answers, one word. We really want to hear from everybody. Keep going. We've got 6 responses. This is a little harder. I see, yeah, cost is coming up in the chat. Anxiety. All right, let's keep going. Trying to get up to, I'd like to see 25 responses, same at least more. Got some shy people on this call. Maybe you're just taking time to process. All right, we'll stop there because I think we've got a good basis from which to work. And Dr. Edwards, I'd like you to respond to this too. You mentioned this in your comments, what was happening with your own patients as a result of Medicaid unwinding, some of the challenges that people face. So do you want to respond to this question?
Sure, I think that's such a great question. And I think for a lot of us, sometimes the first thing we think of is payment or insurance cost. But the fact that trust came up first tells you how much more um, responsibility we have to decrease that anxiety by, and I'm going to quote Emily with what she said, meet patients where they're at, be non-judgmental, know that their worries, concerns, challenges are going to be embraced in our offices without judgment, because sometimes that is just walking in the door is going to be the most significant barrier. Just because you have insurance doesn't guarantee access. And that is such an overarching statement. But the fact that it's the relationship that you and I, Emily, value so much, and that came up as the first barrier, puts a lot of onus and responsibility on us. So I think that's what struck me the most. So thank you for whoever put that comment into the Mentimeter.
We're going to move on then to our discussion. I appreciate everybody taking the time to answer the question because I think it informs as we go forward talking about these issues, in particular chronic disease, what's happening with infectious disease in Texas, and non-medical drivers of health. And so, kind of leaning back into what we saw from America's Health Rankings, we are seeing, unfortunately, more Texas adults report being in poor or fair health. And there are, of course, many different chronic diseases that impact Texans, but these are some of the top ones: diabetes, hypertension, cancer, and mental health. And we talk about obesity. We're going to talk about that in a minute, just because both Dr. Briggs and Dr. Edwards have been involved in trying to address obesity in Texas, and it contributes to chronic disease, of course. And we're seeing more Texans report being overweight or obese. So let's now talk a little bit about chronic disease, and you can take down the slide. We're going to just go ahead and jump into the discussion. Chronic diseases, they're difficult. And to the issue we just talked about, trust, there are lots of factors that affect people's ability to get the care they need. And some of that is genetic. People are predisposed to certain chronic conditions. It's also where they live, what they're able to access in terms of food and safe exercise and so forth. But let's talk a little bit about from your experience in practice, what are, besides obviously genetic issues, which are beyond people's control, what are some of the things you see really affecting the rise of chronic disease? And we'll talk about it both from adults and children, as we know, unfortunately, some of the diseases that have been more prevalent among adults are now being seen in young people as well. So Dr. Briggs, you want to talk about from that perspective, what are you seeing in your practice, things that you think contribute to this increase in chronic diseases in Texas?
Sure. So a bulk of that increase, I think, is related to something that you already touched on, which is the obesity pandemic in Texas and in the United States. We have such a more sedentary world, especially in our adult population, than once was the case. So many jobs involve somebody sitting in front of a screen, especially since the pandemic. More people are working from home, and in that working from home, they're sitting in front of one of these things. Our kiddos are having so much of of their learning happen on devices that are, provided by the school district. So there are a lot more sedentary activities that our families are doing. And without guidance from the medical field, sometimes they don't acknowledge that need to be moving more. And it's something as simple as movement, which is something that we counsel our patients on a daily basis. The foods that we bring into our bodies, the activities that we use our bodies for, if those are not aligned with health, then these chronic diseases are much more prevalent. We've got viruses that have come up, and I know we'll be talking about that a little bit later today. But there are just so many sedentary qualities to the things that we do. So that's what I would say is the primary reason for these chronic diseases being more prevalent.
And would you say, Dr. Edwards, that when you're seeing that, I guess with that trend in more sedentary lifestyle, we're seeing rates of hypertension in young adults, which of course affects them for the lifelong if it's not addressed. We're seeing rising rates of diabetes and so forth. So is it a sedentary lifestyle that contributes to what you're seeing among teens and young adults as well?
Great question. I do think lifestyle choices for diet, lack of activity, even things like tobacco use, substance misuse are all playing a role. But I would also say that environmental factors, when I think about not just obesity, but asthma in children, no question that children who live right by the highway have higher incidences of asthma than those who do not. So I think we need to take into account our built environments. I think that socioeconomic factors are playing a big role in chronic disease. And, hands down, we have an aging population, and which brings the point that in that word cloud that we saw, prevention is so important. So if we can really focus, and I know I'm biased because I'm a pediatrician, but focus on prevention as far upstream as early as possible to address issues like obesity before those complications develop, before we see them in adolescence or adulthood, investing and valuing that unique value proposition that focusing on children has, I think that those are going to help some of those key factors.
So to that point, when you think about instilling healthier habits and taking a preventive approach, as a pediatrician, that's really important. You're talking with the family, and some of this could be intergenerational. That's things they've learned and habits that have to be broken. So how do you instill that habit? And then, as people age and they transition to a family physician, you're sustaining it across their lives. So talk about, some of the role of the in your practice, how you help people adopt and sustain those healthier habits.
I think one, and I take the example of obesity just because we've been talking about that, but I think so in 2023, I was fortunate and privileged to be part of the authorship of the first clinical practice guidelines on obesity from the American Academy of Pediatrics. And one of the things I'm so proud of that really kind of answers the question is recognizing that it is a complex chronic disease that is going to have waxing and waning elements to it throughout the lifespan. So I think one, addressing issues as early as possible. So it could involve early introduction of solids, which a lot of times is intergenerational. It's the way that children have been raised. Just one, asking permission to share information that might be different than what has been shared from a family perspective, recognizing and valuing culture, I think is really important. So when it comes to other behavioral changes, like food and nutritional recommendations, respecting the culture that a patient is bringing into the office and not imposing maybe my own culture, but really making it a shared decision making opportunity to engage them and have them help set the goals and plan for their treatment is important. And as we transition from a child coming to see me to see Emily, just starting those conversations at age 12, at age 13, to just prepare for that patient to be their own best self-advocate on what has been working, what has not been working, to share what the barriers have been, I think is really important.
And so to that point, Emily, thinking about, you know, that transition, and of course you're managing family expectations in addition to those of your individual patient, you know, it also involves bringing in the community in which you live and making sure that that person has access to places to get healthy foods and to exercise. So when you think about, you know, one of the part of our topic today is how primary care, high quality primary care influences community. So is when you're, and I know you go out and talk to your communities about these issues. So how do you lean in on that? You know, that chronic disease is not just something talking about it and preventing it happens in my practice, but how does the community interact with, you know, the medical world to say we need resources to effectively address it? You know, I can counsel, but we also need to think about where grocery stores are located, so people have healthy foods, making sure there are safe parks or pedestrian ways, thoroughfares to exercise, and so forth.
So all of those things that you've mentioned are exactly those touch points. When, especially like in my community, when our community members, whether that's the Chamber of Commerce or the one of the hospital systems or whatever that community member might be, that community organization, when they reach out to the medical community and have us come and talk to their employees, when they have us come and talk with the Rotary group or any of the community members, that engages in a completely different method. So public health is just as important as individual health. And what we're now talking about is that public health. On the individual health, not only that prevention, and I talked about sedentary lifestyles, but you know, we are also in a mental health crisis in the United States right now, especially having had everybody go through this pandemic. And some people experienced that pandemic in a very different way than others, but everybody was affected in minor or major ways by what just happened 5 years ago. So there's a mental health component to this. People want a change, but they don't know how to make that change happen. And so when we reach together to try to get that community in a healthier place, we want to continue to incorporate not only the physical health, but the mental health, and ensuring that when we have an opportunity to improve the location of various community resources, that we're engaging with each other, because we all have those different perspectives. So from the physician standpoint, I'm going to have a very different way of talking to that Rotary Club than a psychologist, than a local civic person, you know, different aspects of that community. But when we come together, we can identify what the needs are. And I encourage our communities to do a needs request, to ask what the needs are for that community, because what's useful for one community is going to be completely different than another community, whether it's, as I refer to my area as micro-urban, which is not a term that is an official term, but you know, we're not suburban, we're not urban, but we're definitely not rural. Our community is going to be different than the big five urban communities, but that's also going to be very different from my more rural communities that we actually pull from for people to be able to come and access care. So what's important to that community, and having our medical professionals going out to the community and sharing what we're seeing boots on the ground can really help to guide. Maybe we do need a park, or we need safer sidewalks for walk trails. We need biking trails. We need things that will encourage our community members to then use those resources and in a safe way.
You know, points to, like, I know, Dr. Edwards, you've done so much around obesity prevention in kids, and that involves like what we can do in schools and working with your community, working with other healthcare professionals. So can you talk a little bit about that? Because it also is going to lead into Dr. Briggs's work working on maternal health, we know that, obesity in young women has implications for them as a healthy pregnancy. So talk a little bit about what you've been doing throughout your career, really to try to address obesity at the practice level as well as in the community.
Absolutely. And Emily, what I will say is what you were talking about in terms of looking at all the barriers, looking at the community, doing that needs assessment. That is so important, not just to address the issue and to treat the issue, but to prevent the issue, because we know that certain things that you were talking about, lack of opportunity for physical activity, increases risks in certain communities for obesity, for the complications. So what you were discussing just really covers the spectrum of prevention all the way to treatment. And I will share that, what I have really focused on is I can't do it alone. I can't just do our clinics, our physicians cannot do it alone. And we talked a little bit about those non-medical drivers of health, or really addressing the gaps and the barriers, because we have to think children come into our offices, but they are there for just a moment in time. We actually have to go to where children are playing and where parents are working, where they're praying, just all look at the entire landscape. And I think those partnerships has really been something that I have focused on, whether it's working with the Department of Agriculture, looking at school nutrition, because children spend so much of their time there, looking at how we can continue to provide nutrient dense foods for children even during the summer, for those who are reliant on free or reduced lunches. Creating that macro environment that will allow children to continue to thrive is so important. And I would push us to even think, I love the engagement we've had through schools, through working on school health advisory committees, to working on school nutrition, but we have to push the boundary even earlier. We have to be looking at daycares. And I know that over the years, there's been tremendous opportunity and success in establishing nutrition and physical activity guidelines in daycares, and that has been incredibly important. But then even looking at how we support the environment for women pre-pregnancy, during pregnancy, and after pregnancy is going to be critical.
And so when you think about, for both of you, because you think about older teens and young adults, there's a lot of focus on obesity prevention, of course, for younger children, but it gets a lot harder when you have the teen years and young adult years. You have social media and influencers and all this, going on. So, what is some constructive ways or things that we could be doing better that really emphasize that, particularly for young women who may not be getting the message that, it's important to have a healthy weight, whatever your body style or type is, so that in the future, if you're planning to have a family, that we know this affects maternal mortality. And it was really highlighted in the last report of the Texas Maternal Mortality and Morbidity Committee that 25% of the cases they looked at had pre-pregnancy obesity. So that's, a lot. I don't know if that message gets through though. So how do we address that more effectively in teens and young adults? To either one of you.
Start. I'm happy to start because I think a message I would love for our audience to leave with is every stage of development and adolescence is important to address these issues. And I would just encourage to start addressing these issues as soon as they are diagnosed, and as soon as you see it, whether it's at 6 months or 2 years, so that we can have a foundation for the adolescent years. But looking specifically at adolescence, I think one thing I want to come away with is that, especially when we publish that clinical practice guidelines, the use and the evidence behind pharmacological intervention or surgical intervention was a part of that. And I think there has been a misperception that that is the answer. But what we hands down promoted that it is not monotherapy. That as a monotherapy is not going to be successful and is never recommended. It has to be founded on what we have been discussing, that foundation of support for those intensive, healthy behavior and lifestyle therapies is critical for our adolescents. So creating that environment that supports those behavior changes, those making the healthy choice, the easy choice, is critical that we recognize and stress is so important for our adolescents.
And so I would completely agree with that. I like to make things as simple as possible when talking to my patients and also when talking with the community. And quite honestly, movement. The more that we can get our families to move, just like we say, you know, the family that prays together stays together. We have all these colloquialisms. The family that moves together stays healthy. And so if we can get more movement, and that involves the entire community having safe, accessible ways to have that movement happen, but also at the school, making sure that movement is happening in the classroom, at the home, making sure movement is happening among the community, choosing weekend activities that might involve being physically active instead of being at home now. But in order to do that, we need safe places for those families to go to. One of the touch points is ensuring that we have that access to care. But as Dr. Avila Edwards mentioned, we have such a small moment in time to be able to impact that patient's care individually. So it's that public health approach that really matters equally. One of the things that we've been able to do in our community is we have a teen health summit that we're doing each year, where we have family docs go into the community and we teach things about hygiene and mental health and safe relationships and all of that. But again, that's the medical community reaching out to the rest of the community and having the rest of the community be open to those conversations.
Oh, I love that. Yeah, I think that truly just exemplifies the role of primary care in community and how you shape that around you. And I know both of you are very involved in that. I do want to transition a little bit to our next topic, which is addressing infectious diseases, which is really today about one and only of the many that we face in Texas. That's measles. So this slide was done a couple weeks ago, and now we've exceeded 500 cases, and sadly 2 children have died. So we know that vaccine efficacy is 97%. It's really the only way to prevent measles. Measles is very difficult to treat once contracted, and so we want to prevent that from happening. So let's talk about measles first, very briefly, Dr. Briggs. I think most people on this call understand how dangerous this is, but perhaps has been lost in the discussion is that it can have lifelong consequences. So that's why we need to get people vaccinated while they're young to prevent illnesses then, as well as when they get older. So can you just briefly describe measles and why it's so dangerous?
Certainly. So as most on this call probably know, measles is a highly contagious infection. It infects 9 out of 10 people who are exposed who are not vaccinated. So speaking to what Helen just mentioned, that we really want our communities to be vaccinated. We need 95% vaccination in a community to be considered having herd immunity, which protects those who are not able to have that vaccine, whether they've got a health condition or they're too young to get that vaccine. But we need 95% of our community to be vaccinated for that benefit. Measles itself, just so everybody is aware, is spread through droplets, so coughing, sneezing, touching infected surfaces. It starts as a high fever, runny nose, cough, red watery eyes, and then it moves into some other stuff. But really, it's that rash and high fever that people are acknowledging. But by the time that rash comes around, you've already been contagious for 3 to 4 days, sometimes even a little bit longer. And and you're continued to be contagious through the experience of that rash, and then for another 4 to 5 days later. So this is a very effective virus from the standpoint of a virus, because before you know you have it, you're already potentially infecting people around you. And that's why it is so imperative for us to protect people ahead of time through prevention. Unfortunately, about 1 in 5 people who get measles are hospitalized, and this is speaking specifically to our unvaccinated community. About 1 of 1,000 people with measles will develop a condition of brain swelling, which can lead to brain damage. Measles can also lead to pneumonia, which is the most common cause of death from measles when the death happens in young children. And 1 to 3 out of 1,000 will die, even if they receive medical care. So that's why this is such an important thing for us to be talking about. Family physicians, pediatricians, internists, we are the ones that are helping to protect our communities from measles and other viruses. But that's why we need to get the word out that this is not something that doesn't affect people. It is 97% you're protected against the measles infection if you've been vaccinated, if you've had that 2-shot series, or if you were old enough to be able to have natural immunity. That can also be quite beneficial. But it is unfortunately spread very easily among our unvaccinated population.
So thank you for talking about why it's so dangerous and why we need to really all work collectively to prevent it. And I know your jobs are a lot harder given the presence of podcasts and social media and influencers who might dissuade parents or individuals from getting vaccinated. So talk about what is your strategy in the exam room, but also just in your communities to talk about and address vaccine skepticism, because it's, obviously you are influential voices to your patients, but also the community. And then we'll talk a little bit, I think, about how you can translate that to other people who can be messengers too. So Dr. Edwards, you with that?
Thank you for that question, because I think that has been the biggest change and the most challenging change that I've seen in my 25-year career is the mis and disinformation that has really inundated our communities around things like vaccinations. And just for the audience, the difference being misinformation is inaccurate or false information that is spread without the intent to deceit, whereas disinformation is false information that's deliberately created and spread in order to harm or deceit the population. So I think my strategy has changed over the years, and I think the most important thing is to acknowledge, and we keep saying this, and we've said it multiple times during this webinar, is to be non-judgmental. Because truth be told, if I had a newborn baby and was not in medicine, and I was surrounded by the flurry of information about, for example, measles, which the only things I would add, Dr. Briggs, you did such an amazing job distilling down, but that virus lasts for 2 hours in the air or on surfaces, and you can see really significant consequences. A lot of people say, oh, I'll get measles and I'll be fine. But 7 to 11 years afterwards, you may have a behavioral or intellectual deterioration coming from something like subacute sclerosing panencephalitis. So it's not just the short term, but the long-term health you have to look at. And I think welcoming questions, asking if the parent comes into my office and says, I don't want vaccines, the most important thing I need to do is to make them feel like I am there to help them distill that information, to ask the question, tell me about that. Tell me about your fears, not to dismiss them, but to acknowledge that they are merely trying to, for the most parents want to do what is best for their child. And when they are struggling with it, to find that strength-based approach and say, thank you for caring so much about your child, but now let me distill the science, distill the information, and show how what you brought in is misinformation or disinformation. One of the things I'm hearing the most currently is how the measles vaccine can cause encephalitis. And so I spend some time going over the science, showing how safe and effective the vaccine is. So that has been my strategy, to acknowledge the fear, to acknowledge the confusion. But I have to say, Kaiser Family Foundation in January of this year released a survey asking across the board, who do you trust to make recommendations for health? And physicians are still at the top. So I will leverage that and welcome in a non-judgmental way that discussion within my clinic.
Yeah, that is really excellent. It gets back to what we heard at the beginning, which is trust, which came up in the Mentimeter about, what people think of with primary care, that you are still a trusted source of information. So before we get into the Q&A, just, Dr. Briggs, you mentioned you're doing a lot of work in your community, as I know, Dr. Edwards, you do as well. But, how do you leverage your voice and amplify it in ways that it gets heard just outside individual exam rooms, or you're just reaching into a person or family? We really have to reach a much broader audience. And so what are some things that from a high quality primary care perspective you are doing, but your colleagues could do to get that word out?
So working with the community, exactly that. We can touch the life of one person to, and one family in an exam room. But when we come out to the community, when we provide that information in a broader sense, we're educating so many members who have actionable abilities where they can assist with that conversation continuing to be brought in a very scientific-based evidence-based approach. So public health efforts are of paramount importance. I mentioned the Teen Health Summit, talking to Rotary clubs. There is an opportunity for any physician who's willing. I think any organization would love to have a family doc, a pediatrician, an internist come to their place of business or to a Rotary club or to some form of some platform to be able to talk about those health-based issues, whether that's vaccines, vaccine hesitancy, whether it's about obesity, chronic disease, tobacco cessation or prevention, all of these things in public health that our voices can be amplified in person in those ways. But I would be remiss to not touch on social media. We have not only the opportunity for mis and disinformation, but we have the opportunity for great evidence-based information to get out into the public. Physicians do a great job on that individual level. We're not always so good about going out and educating the public, and especially now because there's so much misinformation, and that rises higher than the amount of evidence-based information that's necessarily out there in social media. So the more that we can do to our comfort level of going out on social media and speaking to the truth, to the science-based, to the evidence-based practice and care that we have been trained for years to decades, not only in the classroom, in residency and fellowship, but also boots on the ground. For us to share that information more broadly, it really does also have to go through social media.
Yes, exactly. I personally don't do social media, but I have a young son, a young adult son, and he tells me about some of these crazy social media and podcasts and people who are, as you said, misinformation, disinformation. So we're going to go on into the questions. We did kind of incorporate non-medical drivers of health, which was one of our topics, into our discussions about chronic disease. And but one of the first questions, actually from a former health commissioner, Dr. John Hellerstedt, is really how do we engage legislators in this discussion about vaccines? And of course, there's a lot of legislation pending at the Texas Capitol right now around legislation, some of which unfortunately would make it easier for people to get exempted from vaccines, which I know is something both of you have talked with your legislators in the community about why that is detrimental. But how do we talk with legislators about this issue? Because they have a big megaphone too, and can help dispel either misinformation or disinformation. So how do we lean into getting them to talk more about this? And either one of you want to jump in?
So I would say stories. That's the most effective way that I have found in engaging with legislators. When we can link what is being discussed as far as testimony or something like that, or especially when they're trying to plan on certain Senate bills or House bills, as they're drafting those bills, when they reach out, if you have a touch point with your legislator, then they're more likely to reach out to you. But it's those stories that help them realize, because when I tell a story about something that's happened in my community, the human approach to that is to think of, well, how did that happen in my world? And so when we're telling stories, we're engaging with the heart and soul of a person, not just what's the cost, what's the, the risk benefit analysis. The stories are how we get them to align with what's best for our communities. So that's how I would say for us to better engage with our legislators.
I couldn't agree with you more, Emily, because we are victims of our own success, right? I have never seen measles, and I'm fairly young. I know I'm mid-career, but I can tell you I have seen strep pneumomeningitis. I have seen a beautiful young 4-year-old, curly hair, no medical problems, come into our hospital with strep pneumomeningitis and leave completely deaf. So I agree, it's those stories, it's raising awareness, sharing data, sharing information with legislators, raising awareness of what their vaccinations rates are at within their communities, and to share information about the vulnerability that their communities are at, based on lack of reaching that 95% threshold that you talked about, Emily. And I think asking and sharing information. So you talked, Helen, about some of the proposed bills that make it easier to exempt from vaccinations. I think having very honest, respectful conversations about how this will destroy the infrastructure of public health, that I believe in individual rights as parental rights. That's the heart of pediatrics. But I also believe we have a responsibility to our communities, and kind of shattering that infrastructure puts vulnerable children at risk. If you're not old enough to get the vaccine, if you are undergoing chemotherapy where you have lost that ability for your body to fight, if you're older in our community, those we have to appreciate and raise the collective responsibility we have to each other. And I think that is extremely important. And I'll be honest, asking our legislators to, and I appreciate your question, Dr. Hellerstedt, and I think legislators have a critical role in sharing the science, sharing the importance of vaccination. Say the only way to protect yourself from measles is to get vaccinated. To have them, ask them, plead with them to say that is so important. And to also call out mis and disinformation that is being propagated by elected officials, social media stars, whoever it is. I think just correcting that information is really important.
Yeah, well, thank you both, because this is a really critical time when to see this cases. I think just in 2000, the US and Texas were considered measles free. So here we are 25 years later with a pandemic that doesn't seem to be ending anytime soon. An epidemic, I should say. So I'm looking at questions. I know we had some questions in advance. And we have another one from Dr. Hellerstedt, which I'm going to go to about or he just has a comment, I guess, about as an older physician who's been in practice for many years as a pediatrician, what has happened with diseases and the crippling injury or death associated with vaccine preventable diseases. It's still something he remembers. And I will tell you, I was at the legislature one time many years ago when I did have a legislator tell us when we were working on a vaccine campaign that more people die from polio vaccines than from polio itself. And it was really took our breaths away. People who were meeting with this legislator and did bring in a physician subsequently to talk about, what polio does and the success of the polio vaccine, but just how easily somebody can be exposed to mis or disinformation, and then they repeat it, and then it's often a lot harder to dispel misinformation than to get information out there. And people haven't seen these diseases. I mean, I'm sure many people on this call had grandparents who experienced polio. I know I did. And so having not seen it, as you said, we're the victims of our own success, which is good. But now that people are not familiar with the damaging effects of a variety of infectious diseases, measles is one, but there are many others. So if other people have questions, please put them in the chat or in the Q&A. And then we do have, I know we had some that were pre-populated, and so I'm going to actually lean on some of my co-hosts. I don't have those right in front of me. I don't know if Stephanie, you're able to access some of the questions you received in advance. I'm sorry, I don't have those right in front of me, but we do encourage you to put questions in the Q&A. So one of the questions here is, so one of the questions, and this is a tough one, is about how to improve primary care in areas where we don't have enough. So this gets into, I think, one of the questions that we didn't get to talk about, which fully is team-based care. We know that we need more of everybody. Physicians, nurses, primary care clinics, mental health professionals, and they each have their strengths that together really magnify what we can do and amplify that. So talk a little bit about, in the time we have left, how can we really leverage team-based care? We want the legislature, and we are asking the legislature to invest in more of everybody, again, but the pipeline is of course takes a while. So in the meantime, we have to find ways to bridge those gaps. So Dr. Briggs, you want to talk a little bit about that, and then Dr. Edwards?
Certainly. So as Helen acknowledged, and I appreciate you acknowledging that, we have care gaps in our state. We have a very varied state when it comes to access to care. We have 46% of our counties are maternity care deserts, meaning there is not a single provider clinician who provides that care. So that includes physicians, it includes obstetricians as well as family docs, but it also includes our certified nurse midwives, and to some extent even our lay midwives. So there are communities that have zero access to care, and that's exactly what this is speaking to. It's helpful when our community members have more access to, as Dr. Avila Edwards mentioned, insurance, but insurance does not guarantee access to a clinician. We have the wonderful opportunity of having this broad team that can provide that care, and not every member of the team is needed in order to provide that care to be able to spread that across Texas. But we need somebody to be available, especially in our rural communities where we have limited access to care. That's where we need to be planting people that are at the peak of their capacity, their peak of their knowledge. Especially in being a biased family docs are well trained to be out in the community, especially in those rural areas where we've had a broad range of training to be able to take care of not only the minor conditions, but also maybe the major conditions or chronic diseases that have been not ignored, but certainly not addressed because that community member has not been able to access the care. So how do we bring more clinicians, physicians, nurse practitioners out into those communities in a way that is evidence-based, that is keeping that team approach possible? That's where I think we need to align our funding, especially. We need to not water down the training that any of these clinicians receives in order to just get butts in seats, in order to just get people in places. We need to make sure, especially our rural communities, are supported by having that high level of trained physician, nurse practitioner team together going out into those communities.
And let me say then for Dr. Edwards, as you amplify and build it up in the few minutes we have left, one of the questions that came up was about mental health, and sometimes the person who needs to be working with the patient is another member of the team, looking at a psychologist or a social worker. So how do we better integrate mental health services with primary care? Regardless of how that, you set up that structure for a team, and then the couple minutes we have remaining, if you have thoughts on that.
Sure. So I agree that all members of the team are needed and of value. I will get to the mental health question in a bit, but one thing I would say, we have a number of models where, we were talking about non-medical drivers of health and leveraging community health workers to help bridge those gaps and do the closed loop referrals where I know what has happened and ensured my patient got the resources they need. Invaluable. And I think I want to say one other point, that yes, increasing access to care also involves improving part of the infrastructure that is already there. So when I think about children, and I know I don't mean to get us on a soapbox about children, but we have the highest rate of uninsured children, where 50% of kids still likely qualify for Medicaid and CHIP. So how do we improve existing infrastructure? How do we improve eligibility and enrollment processes for children? How do we facilitate and use other team members to facilitate enrollment so we don't have churn where kids who are eligible drop off? How do we improve coverage and care? So to the question about mental health, we have to acknowledge that there are barriers for a patient to see me for a well check and to get mental health services on the same day within existing infrastructure that have to be improved. So taking a critical assessment of the existing infrastructure and identifying opportunities to improve this is also a critical part of that care, so that I can have an integrated health system where I have a licensed professional counselor or a psychologist or a psychiatrist embedded in my clinic. We in Texas have done an amazing job to start things like the Child Psychiatric Access Network that has given me access to psychiatrists and psychologists. I cannot tell you how often I pick up the phone and call them and receive timely guidance and input by my expert colleagues on how to manage something and a patient who is in my clinic in real time. So I think there's a lot to build on and a lot to improve and a lot of additional members of our team to engage.
Well, thank you both. I think we could have gone on for at least another hour. Y'all have so much amazing insight and valuable, perspective that I think the audience has really appreciated. We're a little over time. I just want to thank you again for your participation and sharing with me and the audience what you do to improve patient care every day. We so appreciate your insights. I just want to mention for the audience, we do on the screen is our legislative priorities, and you can find that on the TPCC priority on our webpage. But I also want to call attention, we do have a summit coming up in October, and we're still, as of today, we have open as a call for session. And so if you have a great idea, if you heard something today and you want to run with it, we still are open to your thoughts. So you can get those in on the website. But other than that, if you'll just mark your calendars for October 23rd to the 24th here in Austin, we will be continuing these very types of conversations with physicians and other clinicians involved in the primary care ecosystem. So thank you again for joining. We really appreciate you being part of the discussion, and we'll look forward to seeing you next time.
Thank you for the opportunity. Thank you all for being here.
Thank you.
Thank y'all.